Good evening, everybody, and welcome to this evening's New South Wales coronavirus update. Before we start, I would like to make an acknowledgement of country. So we recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. I will hand over now to Kerry Chant to start us off for this evening.
Thank you very much. I might just start with a bit of a summary of the Australian situation and then ask Professor Sorrell to just describe a little bit of updates from the international context. Australia has identified 15 laboratory confirmed cases of COVID-19. All of the cases had a direct or indirect link to Wuhan, China, and 10 of the cases are reported to have cleared their infection, with the 5 cases understood to be in a stable condition. A number of the cases that were diagnosed in Australia demonstrate the fact that the disease is mild in many and severe in a few. We actually didn't have any of the 15 cases requiring intensive care, whilst there were a couple that did have the more severe end of the spectrum disease but not requiring intensive care. We see that case numbers have increased globally, and we've seen ongoing reports of cases and clusters in a variety of different countries around the world. Probably front and centre is the cruise ship. That has been a significant outbreak in the cruise ship in Japan. The Australian evacuees of that cruise ship have now arrived safely in Darwin and are being managed in Howard Springs, and they will remain there for 14 days. And the reason why they were asked to remain there for an additional 14 days and to restart their incubation period was that there wasn't confidence that the quarantine processes on the ship were sufficient to ensure that there wasn't exposure during that the 14-day quarantine period, hence the explanation for why we were continuing to see cases. I would like to just also address, before I hand over to Professor Sorrell, just the fact that on the 14th we did update the case definition for testing, and I just wanted to explain some of the rationales for that. So clearly we see the highest risk is still in mainland China, and having left mainland China in the 14 days before the onset of illness. GPs should be seeing less patients fitting that category because we have seen a significant decline in air travel from China, consequence on the border measures being implemented whereby only Australian residents or children or spouses of Australian residents being allowed into the country. And so that has seen a pretty major decline in air traffic, and I suspect that may be reflected in presentations to general practice. We have added consider COVID testing in patients who travel to Thailand, Hong Kong, Japan, Singapore or Indonesia in 14 days before the onset of symptoms. Now the purpose of this is twofold. One is to inform us of the risk, the importation risk associated with these countries. And that's based on the fact that these countries, and in the case of Hong Kong, a region of China, represent ports or patterns of flow that have significant flows between China, Australia, and these countries. And so because of that, we're very interested in understanding what is the epidemiology of the disease in those countries and whether there is any community transmission. For instance, Singapore has reported, the Singapore Department of Health website is actually on coronavirus, is quite a detailed website, which actually has blow-by-blow descriptions of each cases, but what they've encountered there is a number of clusters of outbreaks associated with some business events and churches. And I think the question for us is, it looks very comprehensive, but the proof will be in whether they've managed to identify through their extensive contact tracing all contacts and cases and effectively stamp out any ongoing transmission associated with those community transmission clusters. Obviously, this list will be revised And there is talk around Korea and South Korea being another area where there is significant flows from China and then also into Australia. The process is that the Communicable Disease Network Australia meets regularly and considers the modelling information and the international epidemiology, and will update this list. So we will be revising this list, and I think if GPs could get used to reviewing the list of considerations. We're also for our EDs and those that are ending up in hospital, we're also testing patients that have severe illness that end up in our hospitals, and we're recommending them be tested as well as a further assurance that we're not missing community transmission. And we think that that's prudent in those groups, particularly in our ICUs with severe illness, because it's important for the clinicians caring for them to know that, and it's also important for the patient's management. So for that group, we are going to be having not any need for association with travel, but the purpose of that is fundamentally for absolute another assurance mechanism that we're not missing community transmission. Because obviously, depending on a case definition, you sort of reinforce your case finding by having a definition which means you only test a certain group. So we are trying to make sure we don't fall into that trap, but hopefully that gives your GPs an understanding of the rationale underpinning the change in the definition. So Professor Sorrell, would you like to just talk about anything else in terms of the global update, if it's relevant?
Yes, so really just to reiterate some of the clinical features, I think in past sessions we've indicated that although fever occurs in the vast majority of patients, it's not in all of them, and that's reflected in the case definition. Respiratory symptoms, of course, sore throat, cough, shortness of breath, etc. Some patients have had diarrhea, and that's been reported not only in China, but I think some of the Australian cases also had diarrhea, nausea, vomiting, myalgias, etc. So a typical flu-like illness, really. And in our experience, even in a family situation at Westmead, the husband and wife had similar symptoms. The husband turned out to have COVID-19, and the wife turned out to have paraflu. So clinically, it can be quite difficult to distinguish the two, and indeed other respiratory viruses can cause similar infections. It still seems to be the case that the average or the most common incubation period is around 5 to 7 days, but the longest we've seen in Australia is 10 days, and the 14-day period is still what really is being recommended as the potential incubation period by the authorities, and obviously the period for which you self-quarantine in the prescribed circumstances. There seems to be evidence maintained that age and existing comorbidities, sort of serious chronic infections and or immunosuppression, are risk factors for more severe disease and mortality. These are data that are primarily from China, of course, although as the cases and I guess clinical trials get ramped up there, we're getting more of a picture of the actual spectrum of disease. And I think in general it has moved to the less severe end of the spectrum, with the apparent mortality rate falling and still remaining significantly less than that of SARS.
Thanks. So Penny, do you want to?
Yeah, so just to clarify, so I'm seeing a couple of questions here about isolating people after they've been travelling in Indonesia as well for 14 days. So just to clarify that we're talking about COVID-19 testing for patients who've travelled to Thailand, Hong Kong, Japan, Singapore or Indonesia. We're not talking about isolating those people. And also to ask you about whether this is they've spent time there or they've just transited through.
So, very clear distinction. We're not asking anyone in this circumstance that it's transited through Hong Kong, Thailand, or been in Hong Kong, Thailand, or Indonesia to self-isolate. Whilst we perceive that there could be a risk of community transmission in those countries, and we're trying to further understand that, hence the nature of the testing recommendation, we do think that is in orders of magnitude less than the risk from mainland China, and so therefore we don't think that's a proportionate response. But we are taking the utmost of caution of saying, please feel free to test and exclude that novel coronavirus or COVID-19 in that group. But again, to be clear, we are not asking those patients to go into the 14-day isolation. It is only contacts of confirmed cases, contacts of cruise ships or any other sort of outbreak situations that public health authorities deem necessary, or people returning from mainland China.
And perhaps I can add that the recommendations for testing of these people being in other countries doesn't apply to just transiting through the leave.
Thank you. So one of the questions is that given the illness is very mild, are there any plans to formally recommend as part of advice to GPs that they consider telephone assessment and directing patients to get their testing done at the nearest private pathology lab without actually seeing them?
So look, this would be a matter clinically for the GP in terms of how they were happy to assure themselves of the clinical condition of the individual. And they shouldn't treat this disease any different from they would treat any other clinical encounter. So GPs are required to make an assessment about what's appropriate, how they do that based on telephone consultation or, video conference or whatever. But they need to form a view that they can safely dispense under, your professional obligations. But those arrangements wouldn't be inconsistent with how you might treat other conditions. But the question, I think, but you may actually want the patient to come back after they've gone to get the test for assessment. But really, the question is how accurately, do you know this patient well enough to accurately assess them over the telephone? Yeah.
And yes, so if we were clinically concerned, we'd obviously need to see them, but if it was a person who had just very mild symptoms, we might want to do that and then fax through to the pathology lab. And checking in advance, I think it's really important that we actually check in advance that we're sending patients to the right pathology labs that are actually doing the collections, because not all the pathology labs are doing the collections. And so on the New South Wales Health website, there's a tab there that takes you to pathology labs, and you can click on Douglas Hanley Moir, and you can click, for example, and you can click on coronavirus testing, and it will highlight which labs are doing the testing. So in an effort to make sure that suspect cases have the shortest wait and time in quarantine for their results, timely testing is important. This is reasonably easy to facilitate during the week when the private providers are open, but GPs are still seeing patients on the weekends, and the pathology labs are not always open on the weekends. So this question is the only option to swab themselves or to send to ED? Is there any thought of having pathology providers open on the weekends?
Look, I'm happy to take that on notice. I know that some pathology providers open, I know personally on Saturday, having gone there, but let me check about that. And I think that's a really good plan when we may be wanting to test and support general practice in future as well. So let me follow up on that. I think it's a good point.
But Kerry, there may be a presentation. I don't know if Sundays are also relevant in this conversation. And I guess private pathology providers may not be open on Sunday.
No, that's fine. But we may actually, if there is a sort of need to assist in certain times, we might be able to work with providers. So let me take that on notice and we'll raise that with the private pathology providers.
So I'd like to take you through a case that actually presented to our clinic. We got a phone call from, this patient was referred by public health actually from another general practice, and the patient was a 7-month-old and had recently returned from China. They were in self-isolation. It was 12 days after the child had developed some cold-like symptoms, so a runny nose, a very light cough, and the mother was fantastic. She phoned up. And we said, we'll meet you outside, wear masks. So we did that. This was on a weekend. We went and met the mother outside. We took them around the back of the practice and into a room that was immediately available, that we'd set up, that we'd cleared things off the benches, so it was sort of fairly sparse. I had a surgical mask on. I started a conversation with the mother, and we established that this child did actually fit the criteria. It had fever, and it had also had it had a cough, and it also had just come back from China. At the time, we presumed that it was unlikely because of the 12-day incubation, but it still fitted the case. So in that scenario, and I'll take you further through the scenario, but in that scenario, if that patient had come through our waiting room and sat in the waiting room and not declared, and then had come in to see me, what would be the scenario if that child then was then COVID-19 positive or had developed the disease? What would be the scenario for the waiting room management?
I guess if the test had been positive, in theory, other people in the waiting room would be classed as casual contacts, which is defined as being in the same room for 15 minutes or less, which isn't very long. But I guess it would depend a bit on just how close they were. Fortunately, I think it's a very unlikely scenario.
It's very unlikely in this scenario.
It could be a problem if there were a lot of people if it was a crowded.
Yes, and our waiting room is usually fairly crowded, but yeah.
But we obviously want to keep people who are potential cases out of waiting rooms even with a mask, they're better off going into a single room.
So with this 7-month-old, the child was fairly well, which was a nice thing. They both, mother and child, were wearing these wonderful masks with Panda Bear on the front. So I had my surgical mask on. I examined the child just with a surgical mask on, nothing else. And the child basically had some upper respiratory tract infection. I then decided that I would do the swabbing because the child was quite mild. If the child had been sick or had been coughing quite a lot, I would have probably referred to ED. I basically then put on my PPE, so I put on the gown and the mask and the goggles and kept the surgical mask and gloves. And then I did 2 nasopharyngeal swabs on this child, and I labelled it and put down the date they'd been in China and the details of the symptoms and requested coronavirus as well as multiplex respiratory PCR. And we sent those off to the laboratory. And then I derobed, obviously, and I continued chatting with mum and gave her information about isolation. Now, this family had already self-isolated for 12 days. So we didn't get that result back until 3 to 4 days later, by which time it was 15 to 16 days. So my question is, what do they do about isolation over that period of time?
So I suppose I'm a bit horrified that you didn't get the result back that
It was over the weekend.
It doesn't matter. So again, I'll follow it up with the private pathology. But if our labs have been working our labs work 7 days a week. So I suspect it is because it went to the private pathology and then didn't get decanted to the novel coronavirus. So it's a good point for us to think about how those specimens can potentially, even on weekends, get transported to the hub. So let me follow that up with the privates. But just to let you know that our coronavirus testing is we're doing often two runs a day across our 2 sites, and they're coming back, and most people will be cleared in the same day, provided that the specimen gets there for the run. So it's the lag of probably getting logged with the private and then coming back. I'm happy to follow that up and think about some of those logistics. We're also scaling up our testing to 3 more laboratories over the coming weeks. So that will be Liverpool, Royal Prince Alfred and North Shore, and then have the capacity to do others. Also, the private labs are obviously, some of them are very keen to do the testing themselves. At the moment, there isn't a sort of validated test, but I suspect in a period of time, once those tests are validated, then I think there would be general support for access through the private facilities to the test as well. So we'll keep you updated on that, but it's not in the near horizon. So let's work through some of these logistic issues.
Can I just add something to your scenario, Penny? You probably did it, but you didn't mention it. Respiratory and eye protection is obviously very important, but I think the other thing that's often underestimated is the importance of hand hygiene and contaminated surfaces. So, this is probably actually one of the more important ways that respiratory infections of all sorts are spread. And I think we underestimate that. So I recommend that when you describing the scenario, you mention the hand hygiene, particularly before and after you take off your mask. And maybe even try and wipe the child's hand. I mean, kids are messy little creatures when they've got respiratory infections, and they do spread their secretions about. And I'm sure that's why we all get respiratory infections from little kids. And so it's just worth emphasising that. And then when you're finished seeing them, if you can wipe down the surfaces that they've touched or been in contact with before the next patient comes in.
Thank you. That's very good advice. And so in terms of what I'm going to wipe it down with, what would you recommend?
Well, a good detergent, or preferably a detergent disinfection wipe of some sort. There are plenty available TGA listed detergent solutions and wipes.
And there's a good summary of that also on the New South Wales Health website as well, straight to disinfectant. So I guess the other question that wasn't answered. So in this scenario, the patient had already been quarantined, self-isolated for 12 days. And so it wasn't until after that 14 days would have finished that we actually got the result.
So that's a sad thing for the family in being in isolation longer than they needed to. So I haven't heard of any other positive results. So I'm assuming this result is negative because we've only got the 4 results. So the sad thing is this person was in isolation for longer than they needed to.
But they couldn't come out of it until you got the test
but they
result.
can't come out of it. Yeah, it goes without saying that they can't come out of it until you've got the test results.
And then the last thing I had to do, of course, was when I got the results, I actually then phoned the mother and talked to the mother. And the mother actually had questions, and she was worried, interestingly, that she might get it. So she worked in a sort of a retail business, and she said, how do I not get it? What do I have to do? So there was a lot of advice there around that. So that was very, very interesting. So one of the other questions that's coming up here is there's been a couple of questions around whether GP should be doing chest x-rays or CT scans to diagnose coronavirus. And so I don't know if you want to comment on that.
Well, I mean, we've recommended that if the GP assesses the patient as having clinical signs consistent with pneumonia, they probably should go to hospital. And I think that's a reasonable request. I mean, I can imagine that some patients with pneumonia are well enough to stay home and they might do x-rays, but in this setting, I think it's better if they go to hospital.
I think one of the observations has been with some of the cases, though, that the appearance of the chest x-ray is worse than the symptoms and signs would actually suggest. So it's like an atypical pneumonia, really. The x-ray appearance can be. So it's just a point to note that even though the chest signs might be relatively mild, the x-ray may look somewhat worse, and the CT may look maybe abnormal when the chest x-ray appears normal.
But if you're going to test them,
you would do that in a hospital.
If they're well, and if they're well enough, well, I mean, if they're judged to be well enough to go home, even if they have got pneumonia, until you get the result of the test, they probably don't need to go to hospital.
So there's also been a little bit of discussion around the name of what COVID-19 means and SARS-CoV-2. So can you explain which is the virus, which is the disease? I'm going to call everything COVID-19 because it's easier.
The disease.
I think it's a bit unfortunate and confusing actually, because of having different names. But the virus itself's been called SARS-CoV-2, just as the virus that caused severe acute respiratory symptom was called SARS-CoV. But it was a bit easier because the disease was called SARS, and this one's called coronavirus infectious disease COVID-19, which is just slightly confusing. I think most people are just going to call it COVID-19 and forget about SARS-CoV-2.
I think in naming it, there was a lot of concern to not have a place name, and they wanted a syndrome sort of name, and the syndrome was severe acute respiratory syndrome, similar, and the genetics or the genomics of the virus was similar to SARS. But I think it is a rather unfortunate, in my view, misnomer because it confuses you with SARS.
We certainly wouldn't want it to have called it Wuhan disease or something like that, China disease. That would have been very unfortunate and completely inappropriate.
And
COVID's all right. Everyone's got used to COVID already in a week, I think.
I've also seen some sort of graphs showing a decline in numbers in China and in Hubei province. Can you talk to that as to what's sort of happening, what the projection is?
Look, I think we recognise that China's taken a lot of traumatic sort of actions and inactions that would be very hard in other settings to do. So I'd just like to acknowledge that. And I think that the data is showing the cases in Hubei province are still the epicentre, and the activity in the other provinces is more patchy. I think, like all things, we also know, I suppose, another thing, that lab capacity in the other provinces is actually quite high, and I suppose some of the mortality reports from the other provinces indicate they probably are picking up the milder diseases, and so testing is likely to be high. So I think there are always challenges with data, and sometimes you saw the rapid jump if they're collating cases or they're batching the results and the upload. So, we will watch the data, but a day doesn't make a trend, and I think the issue is we will observe over a period of time to be absolutely sure that we understand, and also triangulate it with other data. I mean, it's pleasing and reassuring to see the fact that we've seen probably around 19 to 20,000 people returning from China. Those have come from outside of Hubei province because no one is able to get out of Hubei province at the moment. And what's been interesting is we have not picked up one case and we've had a very low threshold. Basically anyone through the airport with a bit of fever and has gone off to the, with some runny nose and stuff, has gone off for testing. And we have not. We've picked up a variety of other respiratory viruses, but we haven't picked up this. So I think that gives us some comfort, but we are very conscious that no one piece of the puzzle has the full picture, and everyone is looking at multiple pieces of the puzzle to conclude the effectiveness of the Chinese measures. But also we have to have a view to what's happened in the rest of the region. So China is there, but we need to understand what's happening in Southeast Asia and other parts of the world which are close, where we have lots of close travel, because issues or community transmission in those countries could similarly provide a point of entry into Australia. I don't know if you want to reflect on.
Well, I mean, just to reflect that there was one day when there seemed to be quite a massive increase in the number of cases in China, and then the next day there were hardly any, and clearly, it was just delayed reporting. So there's, as Kerry said, we've got to look at trends over time and what information we can get about testing and how many people can be admitted to hospital, how many people are being turned away. It must be very difficult to manage at the epicentre of this, even with their two rapidly built hospitals.
There's also been discussion about the case fatality rate being lower if you look at those outside China. So previously looking at above 2%. And I think the latest I saw was, is it 0.6% or something like that? Is that about right? Or
certainly a few days ago, some modelling suggested around 0.9%. Okay. I haven't looked today, and things do change quite regularly. I think there are a couple of issues, and my personal view is that the 0.9% is getting closer to the truth. I still don't think we have a definitive number, but I suspect it will be lower. The two issues that have to be weighed are people have a tendency to say, well, this number of cases have died in China and this number have been diagnosed. The trouble is that's sort of on the same day. So the ones diagnosed have not yet necessarily died, if you see what I mean. So you can't do a strict division because you haven't actually got the follow-up data on the patients that are being proven or diagnosed at that point in time. On the other hand, because the system's so overwhelmed, there are an enormous number that probably aren't even going to hospital because they don't feel that unwell. And if they do go to hospital, they're not necessarily able to be seen or tested. And that's where we think the long tail of less severe is likely to move the mortality rate to a lower number.
We should remember that China hasn't got a good primary healthcare system, and so probably people either went to hospital or decided not to go to hospital, and when they're busy there really isn't an alternate pathway. So we're very blessed in having such a strong primary healthcare system, and I think to some extent it is the envy of China in terms of, I know that they've been, from my visits to China, they've been trying to re-establish primary healthcare, and that's really been challenging for them.
So this also leads me, there's been discussion around the word potential pandemics being mentioned. It's been described as an outbreak. It's a public health emergency. What exactly, when would this become a pandemic? What would have to happen for this to be declared a pandemic, I guess?
So we have in New South Wales a pandemic influenza plan, and we wrote that to actually encompass viruses spread through the respiratory route which fit into it. So give us ultimate flexibility so we didn't have to rewrite a plan. The Commonwealth have now had a plan for pandemic influenza and have now developed a response-specific plan for coronaviruses, which is up on their website, and we can circulate that link for your members. But basically it draws heavily from the National Influenza Plan, because that plan really had a very flexible approach. It basically took you through the steps in a pandemic response and outlined the suite of measures or the considerations you'd have at every phase. So New South Wales has activated our plan and has been acting according to that activation. The key elements that we know is that this has pandemic potential. It's about no little pre-existing immunity to the pathogen in the community, the evidence of patient-to-patient transmission. I think the cruise ship clearly shows that it can be in certain circumstances quite effectively transmitted, and certainly the escalating cases in Hubei province showed us that. So, and we've got evidence of sustained transmission outside of that. So clearly it meets that potential. The question is it contained within China? Or at the moment we know that in Hubei it is having a major significant effect. It's then the question in what's its impact on China? And then for it to be a pandemic, it has to have an effect on the rest of the world. And at the moment we're in this sort of watch and wait phase where we really have to understand we're learning more about the virus, and there's some characteristics of the virus which make it much more challenging to contain. So we're currently in containment. We don't have any evidence of transmission outside the imported cases that we've had. We have no evidence of that. And in Australia, the cases that we've had have all been linked to the overseas travel or that small travelling group where there was some transmission within that very well contained group. In terms of whether this virus is able to be contained, sometimes it's about the characteristics of the virus. So you can imagine that a virus that is got a mild presentation is harder because people don't adopt health-seeking behaviours. So that's a challenge. If it's very infectious around the time that you get symptoms, because you may not recognise you've got symptoms, so again, that's a harder virus to contain. It also goes on the intrinsic characteristics, what we call a reproductive rate of the virus. So that's how many people, me generally, will infect, and that reproductive rate, I think, Tanya, correct me, they're thinking around 3 or 2 to 3 at the moment. But clearly also we know that some of that data will be context specific. So that in a crowded situation, the reproductive rate might be quite higher. So again,
And infection control precautions will
will reduce it,
yeah.
and social distancing and some of the things that we can do. So that's the characteristics of the virus which sort of intrinsically say whether it's going to be easy to contain or not contain. The other clear issue is whether you've got a vaccine or not, and we're not going to have a vaccine on the horizon for about 18 months, according to the World Health Organization, and that's been consistently sort of the views of a number of experts. So, and we don't have an effective treatment. You know, we don't have a treatment that could knock it off and cure it and use and add that to it. So then there's the characteristics of what's going on in China, and has China effectively contained it? And then there's the question about, well, what's happened in adjacent countries, what's happened in our region, what's happened in other countries. And the effectiveness of our ability to contain this is dictated by the virus, China's response to it, other countries' response to it, and the recognition ultimately we're in a global community. And so whilst we are an island, and whilst we can have border measures and other things to buy us time, if there is community transmission sustained in a variety of different countries, it becomes to some extent inevitable that it will be come into this country.
I guess the only other thing I would add, as Kerry said at the beginning, the strict definition of a pandemic is that there has to be sustained spread outside of a given continent or country. But people often tend to think that pandemic has to mean severe disease. In fact, the severity of the disease is not part of the definition of pandemic.
And I think that's what we learnt during H1N1, wasn't it? That was a mild pandemic rather than a...
It was a pandemic of mild disease.
Thank you. Mild pandemic. That's a much better way to put it. Mild pandemic.
But I think one of the interesting things is we went through the pandemic with some of the challenges we've encountered here, where the initial estimates of the severity of the disease were quite high, quite frightening, and that related to the fact that we were only capturing the more severe disease in presenting to the hospitals in Mexico, and it wasn't until there was further testing and I think even serological diagnosis that there was actually a clear understanding that it was actually widespread in the community. So we are actually grappling, and even though it feels like it's quite slow, given we're only in early February, we've actually learnt quite a lot about how this virus spreads, its behaviour and its clinical presentation, and I think that reflects the information sharing and the way that the world is actually working together to really understand this virus and how to effectively contain it.
I guess the other thing we learned from H1N1 is you can't always predict who's going to be at risk, because although, I mean, it was well known that in the past that pandemics often affect younger people, and with H1N1, the over 85s were hardly affected at all, which is the group that usually are. There's no reason to believe there will be any particular group that's at higher risk in COVID infection, although children seem to be at relatively low risk. But we still don't know that entirely, and I think that remains to be seen as well. Just who is most likely to be at risk and who might get severe disease.
And I think if we had to predict that from some of the earlier data, it is suggesting elderly and those with underlying comorbidities are the ones that have severe, and there seems to be a relative sparing of the children. And I think what we're grappling with is to understand how children may actually be becoming infected and are they becoming immune. But even though they're having mild disease, they may well infect someone else who has actually more severe disease. And this is really important because, as we know, we have a lot of roles of grandparents and others very actively involved in the care of children. So we have a lot of settings where children come into contact with people with comorbidities and the elderly, and that's a positive part of our environment, but we really do need to understand the risks and what other messages we're going to give in that setting. So that's probably an area that we really need to rapidly understand.
We really don't understand it.
And I guess that comes to, when is the spread? So, the more severe disease, obviously we're thinking more likely to spread. But then there's that, pre-symptomatic or early symptomatic. Is there any update on that as to infectivity around that time?
Look, not validated. I think there is evidence that asymptomatic spread occurs, and I think the information coming from the cruise ships will probably be helpful in that context. So I think we're making an assumption that with minimal symptoms or just before their development, spread is possible. But I think it's also important to point out that in any pandemic, it's the symptomatic patients that spread the virus in the vast majority of instances.
And I just wanted to mention too that in terms of looking at what the process is, so the AMPI talks about the process during a pandemic. The RACGP's also got a pandemic flu kit, and that was produced in 2014 to align with the AMPI, and it also goes through the stages of preparedness, response, initial action, response, targeted action. And so we'll send that link around as well so people can see where we are and what sort of tasks there are for GPs. Not saying that it's a pandemic, but seeing that we're responding to it in a similar way. So there's a question come up here, and I guess if I go back to my case of this 7-month-old, if the swab, so the question is, if the swab had come back positive, what would I then do?
Well, then the child would probably, so then the issue is the clinical status of the child. I think early on we would probably be keeping a close eye on the children, and for containment purposes, given the things, that child I suspect would be admitted to one of our 2 children's hospitals. And then public health would then look at the issue of who else was in the household. We would probably work through those issues, confirm that the parents had been actually self-isolating and the child had not attended any other functions. Public health will work to do that, but we may need some support. If you hadn't been as vigilant and got the patient in the back, we would then do the contact tracing or assessment of who else was exposed, and then the public health units would follow up those contacts in accordance with that guideline document, which defines close contacts. It also defines casual contacts, and the advice we give and how we discriminate between those 2.
I think both those definitions and whether or not patients have to be admitted to hospital when they're not really sick will change as the epidemiological situation changes. Just in this containment phase, when we're trying to really stop it spreading locally, everyone with a positive test is being admitted to hospital at the moment.
And if I now maybe I forgot to put my mask on and forgot to wash my hands. So I've seen the patient, and I was in with the patient for half an hour before I realised that they actually.
Maybe not do that.
I'll try not to. I think I'll just wear a mask for everybody. So now I'm worried about what happens with me.
Okay, well, if you fit the definition of a close contact, and I'm so pleased that you didn't, because you did everything correctly, then unfortunately the recommendation is that you'll be going to self-isolate yourself, and that's really important. And we appreciate the burden that places on GPs, and we understand there'll be circumstances where you do everything right and then some piece of critical information comes out in some incongruous way. So there's no blame attributed to this, but you would have to then be staying at home isolation to protect your patients and your loved ones.
And so when I go home, I'm obviously worried that I'm going to give it to my family, and so I will self-isolate. But say I've got a couple of young kids at home, and I know we've got guidelines, but can you talk me through what I would do in isolation?
Look, I think that's really challenging with kids, because kids, depending on the age, just knowing they're really hard to contain. I think there really has to be made decisions about how, on a case-by-case basis, is grandparent, are the grandparents, I went there too. I've had a great grandmother that would have just adored a reason to have the children. But that's why I'm saying, on a case-by-case basis, just make those decisions about the practicality of it and what are the workarounds that you can put in place. The guidelines, I think, are quite specific and good, and sort of try and get a pragmatic approach to how you can go into common areas and things like that, so you're not just kept in your room. How you can walk outside, how you can do some stuff in your garden. We do need to watch the mental health of people and making sure that people kept sane in this time.
Including Granny, who might have loved having them, possibly not for 2 weeks.
Her mental health's very important, exactly.
Right.
Yes, and lots of hand washing, and you can use the surgical mask as well, of course. And I guess one of the roles of GPs in that situation, because we do a lot of mental health, would actually be to ring and touch base with that patient and make sure that they were going okay. So I guess I will touch on the P2 mask because that's something that comes up a lot.
Yeah.
So are we sure that we don't need to be using P2 masks, or when would we need to use P2 masks in general practice?
This has obviously been a source of a lot of debate and perhaps argument. The infection control group is confident that surgical masks are safe for the vast majority of routine care of patients who even confirmed cases, let alone suspected cases. The exceptions to that are aerosol generating procedures, which include things like bronchoscopy and intubation and things that usually occur in hospital. And if that's decided that it's needed, they should be referred to hospital where specimens can be contained and they can be examined in a negative pressure room. And the only other exception is that although it's probably not what we would strictly call an aerosol generating procedure, in a patient who seems really sick and who is coughing a lot, well, first of all, we'd recommend that they be referred to hospital if at all possible. Sorry, I'm a bit hoarse at the moment. Excuse me. It's all right. The water doesn't seem to be helping. So if they seem to be sick enough that you would want to be referring them to hospital, better not to take the specimens at all, but send them there. If for some reason they can't be sent to hospital, then that's when you might want to use a P2 respirator to take the swab. But we certainly wouldn't be recommending in general practice, by and large, that P2 respirators need to be used at all for these patients. And if it looks as though they're likely to spread, I mean, not so much aerosols, but just more forcibly spread droplets by severe coughing, then they should probably be referred to hospital.
And I guess there's a couple of questions coming up, and I know we've already mentioned this, but I'm just going to ask again. So one of the questions here is, if as a GP we start to develop a viral illness with no clear history of contact, would we be able to get testing on ourselves just to check?
I mean, we wouldn't recommend you test yourself, another member in that, like your doctor. We encourage all doctors to have doctors. It's really important. And one of those doctors so we are not going to, we are offering, these are the guidelines, but we also respect the capability of GPs to assess particular circumstances and make those decisions. But these are our guidance documents and we strongly encourage that. But if there is a particular circumstance that is not covered by these, you can request the test.
Even if they haven't seen a patient who they suspect?
Oh, no. But, I mean, there's some of the considerations that if they've seen patients or they've had a high predominance or there's a particular reason for it. So I suppose what I'm saying is these guidelines don't cover every scenario. I mean, there's circumstances where people give vague stories of having been somewhere with a cluster of illness or something like that, and for absolute assurity, then you could do it. So case by case basis.
It's worth I absolutely agree. I'm not disagreeing with that, but it's worth emphasising that even if they have seen patients who turn out to be positive, if they've been using the right PPE, then the risk is minimal. It doesn't mean they shouldn't be tested if they develop respiratory specimens, but they shouldn't be afraid that it would be very unlikely if they've been using appropriate PPE.
And I understand we've had no GPs with COVID-19, is that right?
No, all of the patients have had travel history there. But I think it is important, particularly if we move to seeing sustained transmission. And as I said, I preface that by we are in containment. We've only had the 4 cases. We do not believe there's any evidence of secondary transmission. But if we fast forward many months and we're in a different situation, then it really is important that we take infection control seriously. And I'm having the same discussion about infection control in our emergency departments, in our ICUs, so it's not just with GPs. We all probably become a little complacent, and it is the wake-up call that this is giving us. But as I think I mentioned it last time, we're worried about measles. There's also some other weird and wonderful bugs that sometimes people have from overseas travel, like Candida auris and things like that. So there are lots of things that we do need to have a good understanding as GPs, as EDs and ICUs of infection control. It's probably not been something we've done enough about, I think, is what I sort of
It's not for want of trying. The message often isn't received unless there's a crisis. I think it's worth mentioning that there are records of healthcare workers in China becoming infected, but I think there's a number of things that should be remembered about that. First of all, the rates of healthcare worker infections is much less than for SARS and MERS, which is encouraging because both of those have been associated with quite high rates of, particularly in hospital worker infections. The other thing, of course, is that the doctors and other healthcare workers live in the same communities as the patients where the disease is spreading, so we don't always know that they have acquired it from their own patients. I mean, there's clearly a lot we still don't know about healthcare worker risks, but I think we're all pretty confident that the infection control measures that we're recommending will keep the vast majority of healthcare workers safe. You know, there's always breakdowns because of, people are busy or there's an emergency or something goes wrong, but by and large, people should be confident in what they're doing and not feel unduly anxious about it.
And I think the other issue about the transmission in China is that the hospitals were sort of overwhelmed before this epidemic, and so the chances of appropriate infection control being able to be practiced are really quite substantially less than is the case here.
Yeah. And they were short of PPE, and doctors rapidly became overwhelmed and overworked and exhausted. I mean, it's not good circumstances as far as we've heard from particularly the big hospitals in Wuhan, where they were turning people away, but the ones they were looking after must have been very difficult to manage.
So there's a case scenario here that's just come in. So if the children come back from China asymptomatic, isolated for 12 days, now the father who didn't go to China has developed flu symptoms, should father get COVID-19 testing?
No, we would think that would be a total stretch in an asymptomatic child. But I would just suggest, the child's asymptomatic. But I would just suggest that someone talks to the child to confirm it, because what we know is in a couple of cases, sometimes children could be stoic. So I just sort of validate it with them, validate it with the carer of the child or a few people that the child is actually well. So again, these things require verification of these facts because they're so pivotal, but I think we wouldn't be seeing, if the child was perfectly well, that the father would be at risk.
Not likely to have got it at work.
Yeah, exactly. And I know in our practice we're actually seeing a lot of para-influenza and influenza A. So, which actually we have the flu season coming up as well.
Yeah.
And there's just been discussion around when those new flu vaccines for the new season are going to be released. I guess if we're going to start having a bad flu season, for example, what's going to happen with coronavirus in amongst all of that? How are we going to manage that?
This is a topic of much debate, and clearly that's some of the scenario modelling that's been happening, because one of the things that with all these plans is whilst you're in containment, a key element of that is also looking forward to the what ifs. And so just to reassure the GPs that we are thinking about the what ifs. We're thinking about how to scale up lab capacity, what our social media messaging would be, what our messages to consumers would. EDs, we know that our emergency departments are going to get hit, and just because even if there's a relatively low fatality rate, but you've got a very large population without any pre-existing immunity, it's just a numbers game. It's still going to have a significant impact on the system. We need to present some of that data to you once it's been finalised as well, because as GPs, you are part of the solution. You know, we're going to have to work together to get through this should we move out of containment. And, you know, as I said, I haven't got a crystal ball, but it's part of prudent disaster, planning, that you've got to do that contingency planning now. We do know that the modelling suggests that we do have a lag between when you get introduction and when the spread can ramp up. And the pleasing thing is that there are still lots of things we can do to actually flatten the curve, because if you do get disease in the community, what you're actually trying to do is make sure that you enable the health system to cope, because the health system's got to cope, balance the care of individuals with COVID-19 with the care of people needing neurosurgery, the people needing cancer therapy, and we have to have the capacity to provide good care across all of them. And so what we're trying to do is flatten, our aim in those phases is to flatten the curve so that the health system can chug along. It's still not easy for the health system. It's long, protracted and tired. We do really well when there's a short spike in demand because everyone will muck in and do everything, but this is actually really tough, and it will be potentially tough on GPs. So that's not for another day, Penny. We'll have that discussion,
Okay, yeah.
but it is important that we flag that thinking is at least being done as you would expect us to.
It's probably worth emphasising on. I don't know whether there's likely to be any problems with delay or volume of flu vaccine, but once it's available, so long as there's enough, it's going to be important for GPs to really proactively recommend that patients become immunised so we can minimise the seasonal flu epidemic as much as possible.
And also think about the role of Tamiflu as well. In flu, we know that that's probably underutilised, and it may need, when we're tackling this, and if we've got both diseases running, we want to optimise manage for flu and as well as the COVID-19. And so they may be some things that are in your practices. I mean, how do you manage when people potentially with comorbidities come in with flu, and how do they get appointments quickly enough to just get outside the time range for the antivirals, and are doctors up to date with the sort of latest thinking about the perhaps extended period that they can have for the antivirals. So these are some of the considerations that we'll need to have as well.
Yeah, and we can put out good information on that from the college as well. So I've got another question that's here. So it seems sensible for GPs to do phone assessments on patients picked up on triage that have mild illness to reduce their contacts with healthcare facilities, and that could even, I guess, apply to the flu. Unfortunately, as there's no Medicare rebate for phone consultations, the patient cannot be reimbursed and will be left with an out-of-pocket cost if the GPs charge for their time. So how can we help patients cover the cost of seeking primary health care in this potentially pandemic situation?
Can I just suggest that I think this is something that is more for the college to take up nationally. Obviously, the Medicare rebates are, issues with the Commonwealth. Just, I suppose, for some of our preparedness, we ourselves are thinking about things like video, how we might move to video conferencing, and remote technologies to assess patients. That's because it's good practice anyway. We probably know we're bringing people back to have outpatient appointments when we could do the telephone consult, check with them, discuss a few of the results, and it actually is probably cost effective for the individual, not having to pay parking or drive the car and those sort of things. So for a variety of reasons, we think that we can probably use technology more in our part of the system. And I think it would be useful to think about a general practice in the future about what mix you see general practice having in terms of being able to have online consultations and other
But
things
with
as part of the
reimbursement
mix.
for
Yeah, with probably
with
it
reimbursement.
presumably would take almost as long if there's a decent discussion with the patient as it does to actually see.
Yeah, which can be very frustrating.
So I suppose what I'm trying to say is that I think this is probably something where we need to move more holistically as good care.
Mm-hmm.
The GPs need to provide care in different ways, and the reimbursement, that's my personal belief, but I don't find general practice.
No. And so I guess one of the things too is we do know that there's the Health Direct line too that we can direct patients who've got queries around, and there is also a coronavirus health information line nationally as well. And it's 1-800-020-080, and if you dial it, which I've done, if you press 1, you go to for information around it, and if you're unwell, you can press 2 and go, and there'll be a nurse to talk to you about it. So that's another way of sort of helping manage patients as well.
Penny, can you repeat that number for me, and I'll send it out to the chat box so that everybody's got it there.
So the number is 1-800-020-080.
Awesome. So that number will come out to all of you now, so you can write that down for your own records. That does bring us to 8:01. There is one more quick question I'd like to field because it's popped up a couple of times. It's a simple one. It's just around testing and still a bit of confusion around the swabs that they're supposed to do, whether it needs to be 2 NP swabs or if they can do an OP swab. So if we can confirm that for people online that are confused about how many swabs and which type of swabs they need to do.
Well, this came up in a teleconference today, and the laboratory representative wasn't quite sure, but I think the answer is 2 swabs. Personally, I don't think it matters whether it's nasopharyngeal or oropharyngeal or one of each, so long as they're carefully taken and twirled around.
And I think that's the nasopharyngeal. I think we've said the nasopharyngeal and 2 swabs, one that can go for the respiratory, because most of the private pathologies are doing the respiratory panel and then sending on the coronavirus testing to the labs. And that's the preference because it frees up our labs from doing both of the tests. So that's the preference for
Absolutely,
I think it's on our website.
Yeah, so that's right. One's going for corona, one's going, because normally these patients are coming in and you're thinking, have they got flu? Have they got something else? There was at one stage, one of the labs was asking for 3, but I think that's because they thought there might be 2 going off for corona. But as far as what we've just been doing, 2.
That's right.
The Westmead lab is actually doing the complete panel. So they've added the coronavirus to the respiratory virus.
Okay.
The PHLN has actually said they'd like to have sputum too if the patient has a productive cough. We're not pushing that too hard, but that can be done in hospital.
Alrighty, that does bring us to the end of time. There have been some questions that we haven't yet addressed. Obviously, we don't have time, but we will continue to do our best to keep you updated, and we will add to the FAQ sheet that we have offline and redistribute as that's updated to keep you all up to date with the most recent information that we can. So I'd just like to thank Penny, Kerry, Tanya and Lynn again for joining us, and everybody online, good night.